and that can lead to problems with blood not clotting properly, and jaundice. And the other major organ that's involved in children is the heart. And again, the heart can be affected in adult patients with mitochondrial disease, but affected in a slightly different way. As a clinician, I'm always looking for patterns of disease, and sometimes the involvement of more than one organ system at the same time suggests a diagnosis. And so in mitochondrial disease with children, brain and liver involvement is quite a common association and suggests a particular diagnosis. Likewise, muscle and brain are often involved. And increasingly, through our work with colleagues at the Freeman Hospital, we're recognising that cardiac and brain involvement is also a significant, affects a significant proportion of children with mitochondrial disease. And just to think about the heart in a little bit more detail. The problems are either that the muscle around the big pumping chambers of the heart is too thin, and children get what's called a dilated cardiomyopathy, or weakness of the heart. Or indeed that those chambers are surrounded by very thick but ineffective muscle, and that's called hypertrophic cardiomyopathy. And I put these up just to illustrate this point that we can detect some forms of mitochondrial disease very early. And this is an antenatal scan of a third trimester pregnancy. So this is towards the end of pregnancy, and we can pick up particularly this dilated cardiomyopathy very readily on those scans. And just to remind myself as well that the problems with the heart are not just confined to the muscle itself, but also to the conducting pathway, the electrical activity that keeps the heart pumping. And to detect those, we do ECGs at fairly regular intervals, and you know yourselves that you go fairly regularly for an ECG, or you should be. But as a paediatric neurologist, what is often presenting to me are problems with the brain. And those problems with the brain can sometimes be very specific, and sometimes they can be very non-specific and affect lots of different parts of the brain. But the sorts of symptoms and problems that patients come to me with are seizures, hearing problems, problems with the tone, so either very floppy or very stiff, problems with learning, and developmental problems, so that children don't reach the developmental milestones that they should be. And by developmental milestones, I mean the points where we all recognise where a child is sitting by him or herself, or is walking, or is running, or is acquiring language. And those can be problems that present as a consequence of mitochondrial disease. But it is important to remember that the brain is not always involved, and a diagnosis of mitochondrial disease doesn't mean that you're going to get any of those problems. Likewise, although it can be involved, it can be just very specific parts of the brain that are involved. And I've illustrated that here. The yellow arrows on this MRI scan show areas of the brainstem that are affected by the mitochondrial disease, and the patient presented with swallowing difficulties. On these two scans, we show very clear and symmetrical involvement of two discrete parts of the brain, and those bits of brain control our motor movements. And so this patient presented with dystonia, or difficulty with movement, and increased tone in their limbs. But the important thing, and the reason I put this up, is to say that these specific bits of brain don't affect the cognitive function, or the ability to learn and the ability to communicate. They are specific, really, for motor control in this case, and for swallowing in that example. Okay, so that's where we are in terms of the problems that children get. So what can we do about that? Well, you've heard from the physiotherapists today, and you've heard about the research that's going on. But what I do as a paediatric neurologist is I draw on the experience I have from the sorts of therapies that we already employ in other types of neurological conditions. So problems with tone and spasticity, you've heard that word this evening, and dystonia, problems with either too much tone or too little, are common in my practice as a result of many different types of neurological disease. And there are treatments out there available for them. And we utilise those treatments. Things like muscle relaxants, like baclofen, or indeed replacement of neurotransmitter, a chemical in the brain that is depleted in some patients who have the same symptoms. And we've been trying this recently in some mitochondrial patients with very good benefit. The use of physiotherapy, splinting, aids, wheelchair assessments and home adaptations are all extremely important in the management of patients' dysmobility and their problems with tone. I showed you that slide of someone who had problems with their brainstem and how that affected their swallowing. Well, if you can't swallow effectively as a young child, that's really going to affect your feeding and your ability to thrive well. So in managing that aspect, what we do is the 3 A's. We make an assessment, and that involves people like Sue Clark, a speech and language therapist, who may undertake a video fluoroscopy to assess the degree of swallowing difficulty. She may then give advice on the avoidance of particular types of food or the consistency of the diet. And you can remember in young children, the consistency of the diet, very young children, or a very sloppy diet, that may cause particular difficulties. And then, of course, there's the use of applications, such as a nasogastric tube initially, or indeed a gastrostomy, which I've shown here. And a gastrostomy is simply a connection between the outside and the inside of the stomach. It's a reversible procedure, so if children's swallowing improves, we can take the gastrostomy back out, and the hole simply heals over. I just put this slide up just to illustrate the dramatic difference that this can make. This is a growth chart. It's common in all paediatricians in their surgery will have a growth chart. Okay? It's how we plot out how children grow in terms of their height along the top, and more importantly often in terms of their weight along the bottom. And they should go along one of these lines. Okay? So children who are going to be shorter, perhaps like me, are probably about the 9th centile. You're going to be taller, you're going to be up at that top one. Okay? And likewise for weight. So if you're going to be a big bruiser, you're going to be along that top line. If you're going to be a little tiddler, you're going to be along the bottom. Okay? But what concerns us as paediatricians is when we see children going across those centiles. So that weight gain is more or less determined at birth and by your parents, who they are, what size they are. And you should really go along that line throughout your childhood, whichever line you happen to be on. But when we see children crossing over these centiles, that's a worrying sign. Now, you can see from this graph, I've plotted out the points that this child was at certain points over about an 18-month period, their weights over that period. They had an NG tube put in initially, and very quickly that was followed by a gastrostomy. And I don't think I really need to show you where that was.